Okay, so we're going to start off by finding out a little bit about the participants in this call, and we're going to go to the map slide. So if we can advance the slides, please, to I think that it's actually in the instructions tab. If you go to the instructions tab along there, and yeah, if we just advance through the next 10 slides. Okay, and right, so welcome, as it says. There will be some people struggling with audio, and, oh sorry, oops, it's gone back to that. Right, okay, here's the map. So here's the first question, and if you go to the top left-hand side of your slide, you'll see a little pen, and if you click that pen, it'll bring down an arrow, that if you click that arrow, you'll be able to move your cursor across to the map and click on where you're joining from. You can see the first people clicking in there, that's great. A lot of people clicking in from Scotland there, but we've also got people joining us from other parts of the UK, and we're also expecting from the registration list a few people from other parts of the world as well, including Canada, I believe, for early risers in Canada. But we'll see how that goes. So for the last people joining us in there, that's great. Just leave that to run for another few seconds. So you can see from this WebEx that we can annotate, we can get some user involvement this way. And one of the purposes of Public Health Hour is to not only talk about the public health topic, but also to cover how social media works and how technology can help us to engage and interact across geography and across topic. So we're going to advance to the next slide now. And this is a table. Okay, that's good, and that's just trying to get a sense of the type of organisation in which you work. So again, if you can click, got a lot of people here from the NHS, a few people from the voluntary sector. I know from the people who have been registering that we've got some people signing in from academic institutions as well. Haven't got patient representatives. It was an open invite, and that's a pity, but there you go. Okay, so that shows us that we're mainly NHS people. There you go. What we're going to do now is we're going to move on to the next slide, and that's great. This is just, again, using the on-screen annotation. Is this your first Public Health Hour, or have you been here before? We've had 4 Public Health Hours before, but as you can see, the great majority of people joining us today are new to this, and perhaps therefore new to the technology. Okay, and we're now going to move to, well, in fact, there's some other people still clicking in there. That's great. A lot of people joining us there. We've got 200 people registered for this event, and, whoops. Right, now, we're now going to do a little bit of different interaction by going to the chat box. So if you can click on the top right-hand side in the chat box, we can see that there are different ways to interact. We can interact with individuals privately, or we can send chat messages to all participants. And so the question here for now, just so you can get used to technology, is what are you expecting to get out of this Public Health Hour? What's the reason that you've joined it? What are you hoping to get out of it? And if over the next minute or two you can type them in, and we'll be able to collect them, and we'll have a look at them as we go along. So that's showing you some of the features of Public Health Hour. In this current session, we're joined by Dr. Calderwood, and I'm in her office with colleague Richard Lyle. Catherine is Scotland's Chief Medical Officer, and is going to be talking to us about realistic medicine. And as many of you will know, realistic medicine was Catherine's first annual report, and it's received a very positive reception from professionals, the press, and public alike. And it's highly relevant to public health, and in particular the domain of health and social care improvement, which forms an important part of public health. Catherine's going to talk to us for half an hour, and in the second half of the session, we'll be joined by a distinguished panel to discuss realistic medicine, and also to take some of the questions that we've been fielding over the last week, and that you might want to type into the chat box as well. So please do, as we go along, use the chat box to note your ideas, to share information that you think might be of interest to other people on the call, and also to raise questions. And we'll go back to these questions at 1 o'clock. This is your opportunity to ask Catherine and the panel members, Sir Muir Gray and Carol Reid, questions about realistic medicine. So please keep the questions coming in. Now, as ever, we'll be talking about social media during the session. Midway through the session, we'll introduce a tool called Crowdicity that will allow us to crowdsource ideas around realistic medicine. And that started on Monday, and I'm not expecting to look at that in detail and to type during the hour. I want us all to be listening to Catherine and the panel. And this is the Crowdicity tool is for you to interact with over the next couple of weeks. It closes on the 16th of September. And obviously, we'll also be tweeting. And if you are tweeting, use the hashtags of Public Health Hour and Realistic Medicine, and you'll be able to pick them up as we go along. So finally, before I hand over to Dr. Calderwood, I would like to thank Paul Woodley from the Horizons team of NHS England. Paul and Helen Bevan have kindly provided the highly professional WebEx setup for this session. We couldn't have had such a large webinar without their generosity, and it's a nice example of how encounters on social media can lead to positive actions in the real world. I met Paul and Helen through social media, and I'm very grateful to them for their generosity. And at this point, I'll hand over to Catherine to present on realistic medicine. So if you go to that one there, that's great.
Nice video then. So good afternoon, everyone, and thank you very much indeed for joining. I think I've seen that there are over 100 participants, and hopefully some of you can get my video back on again. I'm not sure if you can see me, but we'll work on that in the background. So I've seen very quickly that lots of you are expecting to hear more about realistic medicine, and I know that some of you will have already had a chance to read the annual report, and some of you will be coming to this news. So I suppose I'll start by saying that I took a bit of a risk with this annual report. What I was tasked to do was to have a Chief Medical Officer's report about the health of the nation, and many of you will be familiar with those, the statistics about tobacco smoking, alcohol, physical activity, infectious diseases. And so I put those in my report in a second half of it. So all of that information remains there and is extremely useful and well used. But what I decided to do was to write a letter to the doctors across Scotland, and I chose the doctors because I'm the Chief Medical Officer, and I thought that I had better speak to my own people first. And what I wanted to do was to really try to question the way that we practice medicine in its broadest sense. And I asked these 6 questions that you can see on the slide done as an infographic. So, changing style to shared decision-making, building a personalised approach to care, reducing hard waste, reducing unnecessary or unwarranted variation in practice and outcomes, managing risk better and becoming improvers and innovators. And I suppose I was quite genuinely surprised at the reaction. So extremely well received by not only doctors but nurses, pharmacists, allied health professionals like physiotherapists, and by members of the public who've all written to me or emailed or tweeted to say how much they've enjoyed reading the document, how easily readable it was, but also how they really were finding that all the different suggestions within it about practicing medicine differently were really resonating with them and striking a chord. And in fact, having had, Graham has done the analytics on Twitter just 2 days ago, and you can see those numbers on this next slide that we have ourselves been tweeting about realistic medicine for some time, and over the course of, since the 20th of January, since the report was published, there have now been 3.4 million impressions on Twitter of realistic medicine, and I can quite genuinely tell you that there hasn't been a single negative response. Everybody's response is, how can we do more, how can we implement realistic medicine, and how can you help us make this more than a social movement, I suppose, rather than how can we introduce it more formally into our provision of healthcare. And you'll see those 2 little boxes where Sir Muir Gray, who's coming onto the panel in a few minutes, has a man who's really one of the grandfathers of public health medicine, and you'll know all of his influence in screening in particular, and has long worked for governments and various departments, and he said it was one of the best documents he's read in 44 years, which is high praise indeed. And Ben Goldacre, you may know him as a prolific writer. He's quite a cynical doctor and has a lot of media time, and you'll see that he has also praised the report as being almost unbelievably smart. And these are the sort of comments that I'm getting really because people have found that it resonates so well with them. So what's been very nice is that I feel like I'm not alone. I'm not talking about something that people don't get or don't appreciate. I talk very much about doctors in a complex system, and really doctors as leaders of a multidisciplinary team. I think that I've already moved on to be talking about not just realistic medicine, but the pharmacists call it realistic medicine, and some of my other colleagues have talked about realistic healthcare. So we've already moved away from from it being really just about medicine and doctors. I talk about realism in healthcare, sharing decision-making, informing consent, doctors in the management of clinical risk, and changing our practice to support improvement, as well as the translation of medical research into routine clinical practice. So I think the infographic really illustrates these points very well. I'll tell you two stories about the shared decision-making. So the chief nurse, who I get on with very well, went to visit a man he was at her hospital. She was visiting, and he was brought forward because he'd had a knee replacement to meet her. And she asked him about his care, and she said, "Were you pleased with your new knee?" And he really didn't look very pleased at all. She said, "Well, what's wrong? Is there pain, or are you not able to walk with it?" And he said, "No, it's fine." And she said, "Well, why are you not pleased with what you've got, this new knee replacement?" And he said, and these are his words, "I didn't want an effing knee replacement. I wanted a grab rail." And she looked a bit quizzical and said, well, what do you mean?" He said, "Well, I want to stand on my doorstep, and I wanted to talk to my neighbour, and I couldn't do that because my knee was sore. So I asked them for a grab rail that I could hold on to so I could chat to my neighbour and enjoy a cup of coffee with him. And what I got was a knee replacement, and I still don't have a grab rail, and I still can't stand for long enough, as long as I want to talk to my neighbour." So I wonder, I suppose, I'm sure that man needed a knee replacement medically, clinically. He must have had a significant osteoarthritis and pain, but actually he didn't get what, in fact, he wanted for what his purpose and his quality of life was. So another story, a care of the elderly, physician who runs a very successful hospital at home in Lanarkshire. They have a lot of candidates for their hospital at home, and he received a call when he was actually on call in the hospital from a man who had very well known to the service and had pigeon fancier's lung. And this man was slowly deteriorating, as people do, and was having another exacerbation of his breathlessness. So he went to, they phoned, and Graham thought, well, actually, I wonder if I shouldn't go and see him to see if he would be suitable for a hospital at home rather than admit him yet again. So he went to the house, and he spoke to the man, and during his conversation he said, you do realise that this is all down to the pigeons, don't you? You do realise that you know, if you got rid of your pigeons, your lung disease would maybe stabilise in it, and you wouldn't be needing to be admitted so often. And the man said to him, well, somebody has told me that, doctor. Every time I visited, I go for my checkups, and they tell me that. I know about the pigeons, thank you very much. And Graham could see the man's daughter in the corner of the room, sort of beckoning him out of the room. The man was quite unwell, so he didn't come with them. They went out of the living room, and the daughter said, "Come and see this room at the back of the house." Now, nobody had been in this man's house before from the point of view of treating him. So, in this tiny little room at the back of the house, there were hundreds of trophies that he had won racing his pigeon. And it turns out that this man is one of the most trophied pigeon racers in the whole of the UK. And the daughter pointed out of the back window and said, "Do you see those sheds out there? there are 300 racing pigeons in those sheds, and each of those birds is worth 20 to 30,000 pounds. Doctor, my dad isn't giving up his pigeons. And I wonder whether that's probably a choice that that man has made, and is that perhaps fair enough? And in fact, what Graham did was he hooked up some IV antibiotics, hung them off the standard lamp in the sitting room, gave the man some steroids, and then left him at home. So having that further conversation, talking to somebody about what's important to them, a personalised approach to their care. And this shared decision making comes in, of course, to consent processes, and you'll see in the report I talk a lot about because of the Montgomery ruling. I'm an obstetrician. I still see women in an antenatal clinic on a Friday when I can get there. So the Montgomery ruling was, of course, very important to us in obstetrics. But without going through all the detail of that, I was met by a young surgical trainee on the train. He obviously recognised me. That's one of the disadvantages, perhaps, of being on the television, and it's also a disadvantage if you happen to be buying fish and chips with your children on a Friday evening, and your children are worried about you being seen eating fish and chips in public. And so he said to me, I really like your report. I have changed my practice when I'm talking to patients about consenting them for their operation. And I now say to them, there is another option, of course. You don't actually have to do anything. You don't have to have this procedure if that's not the right thing for you. Just because you've come to see me, I'm a surgeon, doesn't mean I need to do anything for you. So immediately changing his practice, that doesn't cost anything, and already making a shared decision-making style of conversation. So I talk further on in the document about reducing harm and waste, and in fact, I talk about waste perhaps being where we're not adding value for that person. So the two boxes about shared decision-making and personalised care, actually, it's wasteful. Perhaps you could argue that that man with the knee replacement, that wasn't his priority, maybe that is wasteful in the same way as waste is traditionally thought of as throwing things away. So when I think we all need to look at where is the value added, where are the outcomes for the people that we're treating, the people we're looking after. A lot of you are in public health, so where are the outcomes for screening, where are the outcomes for some of the public health interventions, and how can we reduce harm and waste there? What about unnecessary, or as I've now started really to say, unwarranted variation in practice and outcomes? And everywhere I look across the system, I find that there are differences in our outcomes. So obstetrics, I'll take induction of labour rate, that's my own specialty, and across Scotland there is a twofold difference in the induction of labour rate across the country. Across the UK, the hysterectomy rate varies by a factor of 5, and I'm not prepared to blame the women or their wombs or indeed the babies for those variations. If we look at other areas, I was recently speaking to the orthopaedic surgeons at their annual conference, and if you look at total length of stay for somebody after a hip fracture in one part of Scotland, the median length of stay, so that's hospitalisation and rehabilitation, median length of stay is 23 days, and in another hospital a few miles away it's 13 days. Now again, I don't think that the differences in the people that are being treated or the fracturing of their hips is responsible for that variation. Cystoscopy rates across Scotland, a small country, vary by a factor of 4-fold. So, and I could give you numerous examples of that, where the variation is there, and we know from some of these, a lot of literature in some areas more than others, but that this variation is leading to poorer outcomes, that we're not necessarily optimising our outcomes for our patients, which reflects back then is surely we could say that is partly harm and also wasteful. So what about managing risk? And in Scotland we have our world-leading Scottish Patient Safety Programme, which I think has really tackled some of the big issues with hospital mortality rate being one of our big successes. And again, in my own specialty are very good improvement of 20% reduction in the stillbirth rate in the last 4 years. But I also talk about managing risk relating to our healthcare professionals. So we know that managing risk is a very sophisticated process leading to good decision making. But we know that when people are stressed or overworked, that their ability to manage risk diminishes. It's one of the first decision-making skills that diminishes. And what happens is people become very risk-averse. And when they're risk-averse, they don't make good shared decision-making decisions. And they tend to over-intervene, they tend to over-investigate, they tend to over-treat. And so I would say that, in fact, part of all of this movement, as realistic medicine has become, is looking at how we manage risk, but in doing that, are we caring for our staff? Are we caring for people who we're expecting to make difficult, stressful decisions, one after the other in quick succession? And perhaps managing risk better also means acknowledging that and acknowledging that our workforce needs to be cared for in order to do that very well. It's interesting that people think that some of the worries about realistic medicine, some of their concerns would be that because they're talking to people about not intervening, about not offering treatment, that will be seen as negligent perhaps, or as something that the defence unions would want to come and investigate. But in fact, one health board has told me that they have recently received more complaints from families at the end of life saying that one particular case, their elderly mother, had died in intensive care full of tubes and drips, and it was so far away from what that lady had said her preference would be when she came to the end of her life. And in fact, people are talking now about this over-investigation and also over-treatment being something that is in fact recognised by members of the public as being not the right thing to do. So this concern about properly consented discussion about intervention levels is, of course, what the GMC would talk to us about, is a far cry from what the GMC is interested in talking to people about about having been negligent. And in fact, some of the inspiration from some of my realistic medicine document is really from knowing the literature about doctors and how they choose care for themselves at the end of life. So 88% of doctors would not have hemodialysis at the end of life. 67% would not agree to be admitted to intensive care, and 95% of us wouldn't have CPR. So we wonder then, why do we then prescribe these treatments or advise these treatments for our patients when what we would recommend for ourselves or talk to our families about would be something different? And it's that disconnect that I've been really interested in exploring with doctors and other professionals in trying to implement realistic medicine. And so I'm interested to hear your views as well about that. And I come in the last chapter to talk about improvement and innovation, and the chapter itself really talks a lot also about translational medicine, about research translating into clinical outcomes. We know that we invest in research. I think we could invest more in some areas, but I wonder, do we actually implement what our research has found to be what's going to improve outcomes? I use the example of aspirin, very cheap drug, very well-known drug, and we know that it reduces the incidence of cardiovascular events in people who've had a previous event. We know that if we could give everybody aspirin, the risk would reduce significantly. In Scotland, only 57% of people who are eligible for aspirin actually get it. And what have we done about that? Well, what we did was we did some more research, and we have come across a drug called clopidogrel, and it's extremely good and is in fact more effective than aspirin. But in fact, if we were to just give the 100% of people who are eligible for aspirin the aspirin, the difference in deaths saved, clopidogrel would need to be 10 times more effective than it actually is. And so we've developed a new drug without actually perhaps implementing something that we know to work, that doesn't cost money. We've moved on to something else. So I suppose I would throw that out as a challenge to those of you who are interested in research. I very much feel that our research should have really direct links into patient care. And again, I would point you back to reducing harm and waste if that's not the case. I also talk, though, about each individual, all of us in our own work, being improvers and innovators. I think sometimes people feel that improvers are somebody inventing in something. You need to do a big project or have training, and inventing a cure for something or a machine that will do something faster and better. But in fact, I've seen innovation in all aspects of the system, where junior doctors in a ward that I visited, they took the phlebotomy service, they filmed the process on their iPhones and recognised that there were 8 redundant steps in that process. So they streamlined the process, and what they realised over time was that they were actually reducing delay in discharge from a care of the elderly ward, because the blood was being taken when it was asked for, the results were in the notes in a timely way, and there were patient outcomes were improved by people being able to be reviewed and going home quicker. So that's very inexpensive, done by the people who know all about taking blood and not being able to get it, and having the phlebotomist leave the difficult ones till the next day. But those people were the right people to innovate and to change that practice. So I think it's really great that all of you are here. I see 116 participants now. I'm going to flip to my last slide, because I'm really keen to have a chat to see what your questions are like. You'll see my contact details there. There's a Survey Monkey which is looking for feedback on the report. We have a feedback document just about ready to go out, which draws together lots of the themes that people have talked about. My contact details are there. Join me on Twitter. And also just to say to you that we're planning events with the Scottish Health Council and with the Alliance, which is our group of patient support organisations, to talk to the general public, to talk to patients about realistic medicine, so that this isn't happening in a parallel universe where the clinicians are talking in one way. We want to have this conversation and see what the public think about it. So thank you very much to you all for joining. I think Graham's going to talk us through crowdicity, and then we have a chance to answer your very interesting questions. Thank you.
Excellent. Well, thank you very much indeed, Catherine. That was a very thorough but also quick look through realistic medicine, which you could have talked on for days, I think, probably. And we're going to now just hand over to Richard's computer, hopefully, if we can manage that, and demo a thing called crowdicity, which we have been given a demonstration version of for the next 2 weeks, or for this week and next. Now, I need to share my computer. Sorry. I do apologise about this. I'm just trying to share my screen. Paul, can you come in at the moment and remind me how we share the screen here?
If you click to the Quick Start tab.
Oh yeah, of course. Sorry. That's great. I've got it now. So I'm going to share Internet Explorer, and we're going to. Hopefully up on your screen you will see a slide that looks rather familiar, because it's used the images from the Realistic Medicine report. And Crowdicity is a crowdsourcing tool that hopefully all of you who are on the call will have received an invite to join. And it runs from the 5th of September to the 16th of September. And you can see I've used the 6 headings of Realistic Medicine, and under each there's a very simple question that is based on the text in the Realistic Medicine report. And if you visit the site and have a look through the different questions that we've posed for this week, and make your suggestions, then we'll be able to frame a scenario, hopefully, for next week that we'll then be able to work through, that will be of general interest to public health colleagues. And one example might, for example, be the way that we deal with health protection calls, and the fact that there is variation between the 14 different health boards in the way that we manage some conditions. And that obviously has an impact both on the clinical staff who are managing the cases and the contacts, but also very much on the way that the patients and contacts get back to work or get back to fitness. And so that's an interesting area. Also screening, again, considerable variation in the way that we for example, arrange our screening for pregnancy, at the antenatal tests during pregnancy, for example. So post your practical examples of things that you think will help. And you can see an example of a post here. Here's Carol, who we're going to hear from shortly, talking about the use of mobile phone apps to engage. And I've used an example which is from Realistic Medicine, which cites Atul Gawande's study. Well, no, he cites a study on the treatment of patients with advanced lung cancer and early palliative care versus chemotherapy. So you can see that we can put a practical example up, and people can vote and also comment on them themselves. If I click on that, you can see that other people have commented on it. So please do join in. The link is at the top of your page there. It's nhslothian.crowdicity.com. If you haven't registered already, check your inbox. You should have had an invite, and if not, please do get in touch with me, and you'll have had my contact details at the bottom of the email to invite you to this WebEx. Okay, so that's the kind of social media advance that I'd like to show you for this session. We're going to go back now to more of the real world and discuss realistic medicine with the panel of experts that we have. And I'm going to ask them to make their instructions in a moment, and we're also going to take questions from the chat box. And if time allows, we might also get the chance to take questions from participants, but we'll need to work out whether the technology will allow us to do that. But I'm going to ask in turn Sir Muir Gray and then Carol Reid to make their introductions, and I'll pass over now to Sir Muir. So if you can unmute the call, we'll hear your introduction.
Hi, it's wonderful to be with you, and I'm going to be with you in Edinburgh on Monday for the Royal College of Physicians. It's their annual conference, and I'm speaking on the future of medicine, and I'll be quoting extensively from the Realistic Medicine, a terrific initiative from Scotland and from the CMO. Just a couple of words about the way we see the future. Firstly, the future is not like Ben Nevis, a destination awaiting an arrival. The future is like the Fourth Road Bridge or the Fourth Bridge, something we imagine, design and build. And what has been set out in the Realistic Medicine is a plan for what's going to happen. There's a design, namely the shape of medicine and healthcare, and then the plan is the next stage of how it's going to be introduced and changed over the next 5 years. And I would see this as primarily a transformation in culture. No need to change the structure, but the culture. The way I've been thinking about it has been looking at what we've achieved over the last. I've been 50 years since I went to Glasgow University Medical School, the veterinary school I started, and in that 50 years it's been amazing what's happened. But we see three problems in every society: unwarranted variation, underuse of effective healthcare, aspirin for example, and overuse of lower value healthcare, which may cause more harm than good. And elective surgery comes up when I raise this in town halls. Wonderful though elective surgery has been. So we've been thinking about what we call value. So just to finish by summarizing the approach. So there's been four things we've done, particularly in the last 20 years. One is prevention. We need more of that. Two is evidence-based decision-making and research. We need more of that. Three is we need quality improvement and safety improvement. We need more of that. And fourth is cost reduction. But while we've been doing these things, what's emerged and increased has been variation, overuse, and underuse. So we're saying we need to focus on three aspects of value. The first is allocative value. And we see a huge variation in the allocation of resources. And the same happens in Scotland. So in England, the spend in musculoskeletal varies from 6 million to 12 million per million population. But also clinicians, what is that allocation of resources between cataract, glaucoma, AMD, and retinopathy, for example. It's determined by enthusiasts in the past. Secondly, there's technical value. And although they write about value in America, they don't have to worry about the whole population and whether there's overuse or underuse. So it's more than efficiency. And then thirdly, there's personal value, personalized medicine. And finally, to compliment you again, CMO in the department, for me, the smartphone is more disruptive and revolutionary than the genome. And I think the way you're starting to use the phone, which poor people have and poor people know how to use, is perhaps the major disruptor that we can see. So I'm learning a lot already from my involvement in realistic medicine, and look forward to being more involved.
Wonderful. Many thanks, Muir. That's great. And I'm just going to take one word from what you said, and that is disruption. And that's a favourite word I know of Helen Bevan. And Helen, who, as I said at the start of this session, has kindly agreed to provide the IT and host this session, and has put us in contact with her colleague Carol Reid, and she is joining us on the panel. And I wonder, Carol, if you can make your introductions as well, please.
Yes. Hello there. Thank you ever so much for letting me join the panel, and I'm really honoured to be part of this process. And it's just been fascinating watching what's going on with the chat box and also with what's happening on Twitter. But just to introduce myself, I'm a fellow in the Horizons team, Helen Bevan's team, and I'm a healthcare innovator who had the first successful skincare range in the NHS. So we'd like to see that in Scotland. I don't think we have that yet. But I'm really keen on looking at how we can use the new technology to help people make, their shared decisions, and looking about a frugal innovation such as the mobile phone that will enable people to access healthcare from anywhere. And I think, like Muir, that's a major disruptive technology that's going to achieve that. Just a very brief thing to say that I'm talking at Innovation Expo tomorrow around innovation, and I will be mentioning realistic medicine within that as well. Thank you.
Excellent. Great. So we're now over to the panel session, and what we've done over the last week is we've had opportunity to ask questions on a technology called Slido, just a website that allows people to post a question and then other people to vote on the questions that they like the best. And it's entirely open and free technology. And what we're going to do here, and this is maybe a perilous thing, is to put things to the popular vote. We've seen that that's a dangerous activity in all round. But we're going to take the most popular questions from Slido. Now, there weren't many people who participated in Slido, but those who did come up with very sensible and practical questions. And the most popular question was from Dr. Peter Gordon, and he's asked, can the panel comment on the inevitable tension between improvement work and over-medicalization? And then he came on as a follow-up question, well, to provide a bit more detail. I ask, as the term improvement makes it very easy for anyone who questions such work to be characterized as a barrier to progress. And in his use of the word improvement, he's alluding to the improvement science methodology that is being used very successfully across the whole life course. The idea that small tested change lead to a larger goal using plan, do, study, act cycles. So to repeat the question, can the panel comment on the inevitable tension between improvement work and over-medicalization? And I'll throw it open to the three panelists.
Well, let me comment. I don't see there is a tension. The key thing is to think, what are our objectives? Now, if the objective is high value for individuals, then the test of any improvement work has got to be whether that's brought about. So we're seeing a shift in focus from measuring process to measuring outcome. So you could certainly improve you could have an improvement project to improve PSA testing, but it would have a negative effect if we measure the outcome in the population. Similarly, if you look at the 50-fold variation in knee arthroscopy, then what we see there is to do knee arthroscopy better. It's not the issue. The question is, what is the objective of the resources we've got for people with pain in their knee? And the grab rail wins out over the knee replacement, never mind the knee arthroscopy. So if we focus on outcome as defined by patients, and that's what we're trying to improve, and we're doing it within a fixed budget, then I do not see that we're going to cause over-medicalization.
Good. So it's how we frame the question, and that is a very important part of improvement science, the way that we frame the question and define the aims of the work. Catherine, do you have any thoughts on the question?
I think I would bring back perhaps to having an open and honest conversation. I do talk in the report about moving away from the doctor knows best culture. And there was a recent study in the Lancet which talked to, it was American, so these are American physicians, and it talked to them about what they thought their patients wanted at the end of life, what was the priority. And the doctors all said that they thought they wanted to live longer, and that they were therefore going to do whatever it took to help the people live longer. And when they asked the actual patients, so these were the people that these physicians were looking after, none of them mentioned living longer as their first priority. They all said two things. They wanted to be symptom-free, and they wanted to spend time with their families. And I think that if we have that open and honest and very frank conversation with people, then this tension of over-medicalisation, when people understand we want to improve things for them, and that will not necessarily lead to over-medicalisation. It might lead to some medicalisation because that might be what that person and their family, and that's what's appropriate. But sometimes that open and honest conversation needs to include doing less or doing very little. And I also hear from clinicians who feel that they need to do things, they need to operate, they need to have an intervention performed because somebody has come and they don't feel that they have permission to not do something. Doctors are fixers by definition, and in fact that's part of this wider conversation. And I think also I've had a lot of comments from people about saying that they have been GPs particularly. One GP said, I've been a GP for 38 years, I've been practicing realistic medicine all my working life, but I've been doing it under the radar, and what you have given me is permission to be public, that I don't have to hide in my office talking to the one individual patient and worry that other people won't agree with what I'm doing. So I would bring it right back to that open and honest conversation with the people we're looking after.
Very good. And finally, Carol, on this question, you've got lots of experience of improvement science in the Horizons team. Any thoughts on this question?
Yeah, I think I'm also thinking and reflecting back on my time as a nurse on the ward, and actually it's paramount that we listen to what people are actually saying, and that will help us to have the courage to undertake realistic medicine. I think from a QI perspective, we need to challenge about what we're trying to achieve with QI and looking at the outcomes-based approach rather than, looking at the process. So really listening to the patient and understanding what their needs are, and, reflecting back to the story about the person with the pigeons. What might be right for one person is not going to be right for another. So we need to really have the courage of our convictions to listen to our patients and advocate for our patients. And that may be a challenge when we have people wanting, relatives, etc., trying to say that somebody needs more surgery or more of a medical approach. Sometimes actually that's not what the individual wants, and that's quite courageous to have to take that stand. So that's what I would say, is we really need to listen to patients. It's not a cost-cutting measure, and it's not because we're not applying quality improved measures. It's about what are the outcomes for the patient.
Okay, good. Well, thank you. A broad range of responses there from our three panellists that reflect that a lot of the themes of realistic medicine could actually cover almost every chapter. You could, it must be quite a challenge to have kept this neat and tidy within the different chapters. Now, what we're going to do now is we're going to move to the second most popular question from Slido, which was, it's an anonymous question. You can post anonymously on Slido, but a lot of people have asked it on Twitter and through other fora. And that is about what public health can do around realistic medicine. And the question is, if realistic public health existed, how would it differ to realistic medicine? So, again, any responses from the panel?
Well, as a public health professional, can I respond?
That'd be ideal.
Yeah, public health, we've introduced the word population healthcare, population personalised healthcare, because by and large, clinicians don't like public health. If they've said, oh, drains or whatever, there's much to be proud of. So public health, I think, needs to be fully aware of the opportunity that realistic medicine as a concept offers them about engaging with clinicians. Because realistic means, firstly, as we've emphasized, you have to listen to individuals. But secondly, you have to measure things with the population as the denominator. So the last 20 years has been great in quality improvement. But if you only measure the quality, the outcome for the patients who are treated, then for most healthcare problems, the patients who are treated are not those in most need. So I think realistic public health has to take the same approach. And we try to do that in screening, where we try to minimize harm and maximize benefit. But I think there's a big challenge for the public health profession now, both in its relationship with the NHS and at what it does, is to move away from the assumption that prevention is always better than treatment. And it may be. I'm looking forward to the day when there might be a decision to reduce spending on breast cancer screening, which I was involved in setting up, and shift that resource to treatment, if the treatment gives more value to women than the screening. So I think it's just as relevant for the public health professionals as it is for clinicians.
Absolutely.
Catherine, what do you make of that?
Yes, I think that, in fact, the question is about what would the differences be with realistic public health and realistic medicine. I think there are probably more similarities than differences. If I take, again, examples from screening, so do those of us who are heavily involved in screening know that the bowel cancer screening goes out with a pot and a leaflet, everybody gets it from their 50th birthday. And this is Scottish data, 23% of working age adults cannot understand the information presented to them in the screening leaflet for bowel cancer. Another figure is similar, which is that, again, working age adults, around 21% cannot work out the dose of paracetamol for a child from the instructions on the side of the box. So I would say, are we realistic in what our messages are? Do we understand where people's health literacy actually lies? Do we treat the worried well and forget about the unworried unwell? Do we have the right people accessing our services from the communities, which is, of course, where public health is based? And I think that these personalised views are very, very much right up the middle of what public health is. But we've already touched on the differences of waste and harm, and so I would say that we could make a case for every aspect of the 6 questions I've asked, in fact, being exactly what public health is about. And in fact, I don't know the data as well, as I have done for some of these other parts of variation that I've quoted, but I would suspect that perhaps there's variation in how our public health medicine is delivered across the country, across a small country like Scotland and across the UK.
Yeah. And another thing to say is that maybe it's a false distinction between healthcare and public health. Catherine, you've said before that we're not patients or staff, we're just people. And I think that's the same as the public, isn't it? The public is not a homogeneous mass. It is made up of people. So that's another way to think about it. And Carol, finally, do you have any thoughts on this realistic public health?
Well, I think it's been very well covered by my colleagues on the panel, and I'm not a public health practitioner, but what I am is a member of the public as well, and I think that we need to strike a real good balance here to actually make sure that we can embed realistic medicine in our daily practices. Really, you know, I've learned a lot from the document and also from the WebEx and how we can embed those practices in our own care. On Twitter, I'm looking at it now that people are tweeting about the fact of, you know, shared decision making and informed consent and how complicated that can be. And I think we just need to acknowledge that it can be complicated. But, you know, how do we shift the resources from one particular thing to another? It will always be quite a courageous move to do that, but I think sometimes that's the right move to do.
Absolutely. And that was a popular question on Slido as well, was the balance between shared decision making and the provision of evidence-based care and how we split that. It's a difficult question. What I'm going to move to now is a question that frames that quite nicely, actually, and it's a question, again, it's an anonymous question from Slido, and it goes, how can shared decision-making become a reality in mental health matters when declarations of incapacity can happen when people resist psychiatric drugging? Now, it's a very specific question, isn't it? But it covers the issue of shared decision-making and incapacity. And any thoughts about that on the panel?
So I'll start. I think that you're right, Graham. That's a very difficult question, and it has a number of layers to it. And obviously, as somebody with incapacity, that becomes a legislative issue. The experience of people and their families within some of these very difficult situations, I think, would make many of us feel that we could do things better. The lack of involvement of families of people with significant mental health issues. The family has, of course, often lived with this for many years, has been absolutely expert at dealing with the person, at perhaps getting the best from them. And time after time, when I've seen investigative reports or root cause analyses where there's been an adverse event, one of the common issues is lack of communication, which of course may be difficult with that individual, but it actually doesn't happen at all with the family. Where somebody with significant illness may be perhaps discharged from hospital on a pass without their family being told they were coming home or going to going outside of the hospital. So I suppose that it brings me back. It's not answering that specific question in detail. Back to the communication and the person-centred care, and in fact perhaps us communicating, people who know the person best, the family, the person themselves, but also always keeping those people in mind in the loop who are staff members who may know people very well. Some individuals end up with a very good relationship with particular clinicians. Do we always facilitate the correct healthcare professional being involved in perhaps what could be a very difficult situation? Adverse events happen. They're often a Swiss cheese of innumerable different little bits of the system giving way. I wonder though, do we step back and look at the big picture and say, hang on a minute, let's not allow this to happen in whichever bit of my patch. You can translate some of this to your own tricky areas. Do we sit up and take notice when something has happened and wonder, could we actually get some intervention where actually we personally might be able to intervene because we've taken the bigger picture view.
Excellent. Okay, I'm going to pause for the moment before handing over to the other panellists. What we're going to try now, and Paul, I hope this is acceptable from the technical side of things, we're going to take a question from the participants on this call, and this is to illustrate how WebEx works as much as anything, but also to keep the discussion open. Now, on the WebEx screen, you'll see a hand that is shown beneath the list of participants. The offer now is the first person to put their hand up who has a question gets to ask that question. We'll unmute that caller and we'll ask that question. Is that acceptable, Paul? Yeah.
That should be absolutely fine.
Okay, so if anybody has a question, can you put your hand up? And after I've handed over the mental health question to Muir and Carol, we'll take that question.
I've nothing to add to Catherine's excellent answer on the mental health question.
That's great. And Carol, any thoughts?
Only just to pick up what's come up in the chat box, which has come up, I've lost it now because from Diane Graham. She gave the example of, we recently heard from the mother of a young man on depot who was fighting with his care providers to move from injection to oral meds. The consultant listened to what the young man wanted and why, and chose to support him to test the approach. The result was reduced family stress and worked really well despite fears of the clinical team. So I think it is having the courage to test out these approaches and actually perhaps sharing them more as case studies, because that will give people more support to actually do realistic medicine for the right reasons.
And that goes back to a term that Catherine used earlier, and a word that we hear very commonly in NHS Lothian when we're discussing quality improvement, and that is permission. Permission to try out things and know that you're not going to get into trouble, and that the organisation is going to be supporting you. And that is a difficult balance, which we might come back to if we have time. But anyway, have we got a question from one of the participants? Has anybody been brave enough to put it on their hand?
Yep.
Yes?
Mark Hazelwood, I see.
Excellent. Right.
Mark is now unmuted and will be able to ask his question.
Wonderful. Mark, your question, please.
Thank you. And I'd actually tried to get this on the crowdsourced question as well. So, and I really to welcome the focus on the quality of experience of patients and families at the end of life, which realistic medicine offers. And I just wanted to ask whether there are some prospects for actually measuring more systematically what those experiences are. And I'm conscious of the contrast that there is between the really good work which is done to survey the experience of, for example, patients with cancer, and recently mothers' experience of maternity services, with the gap that we currently have to get feedback on patient and family experience around end-of-life care in Scotland. It would be very useful to know the bigger picture. And I think also it's a field where there's been a lot of criticism associated with the Liverpool Care Pathway, and I feel it would be very helpful to be able to have some data which actually shows there's a lot of very good end-of-life care going on in Scotland, but when we're battling with the Daily Mail, we don't have systematic data about the experience that patient families have in Scotland.
Thank you very much, Mark. It's an area I'm very interested in because of this issue of measurement. I think we often talk about, 5-year survival or length of time that somebody will live after a diagnosis. In fact, as I've illustrated, that isn't what the patient or that person is actually necessarily aiming for, to live longer. So we measure our success on survival rate. In every audience I've talked to, I have asked the varying disciplines there to think about what they measure as part of experience, and actually whether they know what's important to their patients, what are the outcome measures. So we know that PROMs and PREMs are coming in more and more. The maternity services have developed those. I also have spoken to the International Collaboration for Healthcare Outcome Measurements, ICHOM, who are world experts in developing indicators, and they in fact contacted me because they were really pleased with realistic medicine as a concept. So what we are going to do, I hope, in Scottish Government is to work with them. This is difficult. I don't think that by any means that people's experience or people's view of how their care should look is going to be easy to measure, partly because it's individualised. But ICHOM, we're going to work with them to try to develop some form of measures. Now, some of these may be proxy, just by dint of having to be practical. But we would hope to do that over about an 18-month period, and to have some way of measuring realistic medicine, or perhaps only some parts of realistic medicine, so that we can start to evidence that actually this is what people want, and that when we're evidencing realistic medicine, of course, my hope would be that the outcomes that people are reporting would improve.
Okay, so we're into the last couple of minutes of our call, unfortunately, but I'll hand over that Mark's question to Muir and Carol as well.
Yeah. Well, this is something I hope to be discussing with CMO next week, because I'm starting to work on a little book with some friends, sort of subtitled "How to Avoid a Bad Death." And we do need to open out the debate, and I'm very happy to speak to Daily Mail about this, or the Sunday Post, if there's still the doc in the Sunday Post. So that we need to start a much broader discussion about this. And one approach would be for everyone aged 50 to prepare in advance, to start advanced planning. Now, it's not an advanced plan, because as Eisenhower said, plans are useless, planning is essential. But I think there's, in the preventive side, we now need to move into a much broader. People had any sort of written record about what they would want or not want. So that's we need a public discussion on this in every front room in the UK.
Sounds like a plan. Very good. Any thoughts on that as well, Carol?
Yeah, I'm sort of thinking back really to my time when I've looked after people on the wards, or when I've looked after them in the community, and I really think there is a conversation that needs to go on there about, what do people want? It needs to start early, like Muir said, but it also can take place, at the time, because when I was looking after people, you had to listen to what they actually wanted and what their family wanted, and I think we need to do that more. And sometimes it seems quite a difficult choice to do because we want to over-medicate it, but it's actually about listening and doing what people want. So I think that conversation needs to happen. And I came into nursing in '93, and I've seen all the changes with the Liverpool Care Pathway, and then how we've gone back into a different way, how we're going to hospital at home, which was a key thing when I came into nursing. And we need to just really focus on what we're trying to do for patient-centred care, as what I would comment. And there's been a comment in the chat box about how do we embed realistic medicine in people's training schemes, and that's a cause very close to my heart around innovation, that we need to get people studying this at an early stage so they have the courage when they go out to do their jobs to actually listen to people and bring about realistic medicine and innovation.
Okay.
So the good news there, Carol, is that all of the medical schools in Scotland have agreed to put realistic medicine on the undergraduate medical students' curricula. So
that's fantastic.
They're going to do realistic medicine in their final couple of years.
Excellent. That's a very positive way to end this call. We're
brilliant.
Into the final seconds, just a couple of words from me to say thank you very much indeed to all the participants and to the panellists as well, and also to Paul and to Helen Bevan for allowing us to hold this call on their IT setup. We've had 200,000 impressions using the realistic medicine hashtag today, so that's quite extraordinary. To go back to the Scots Public Health hashtag, that will next be brought out on the Scottish Public Health Conference on the 27th and 28th of October. But if you found this call interesting, if you want to continue to engage with Public Health Hour and Scot Public Health, you'll find our website, scotpublichealth.com. You'll find details of this event, details of how to continue to engage, and you'll remember also the SurveyMonkey link to realistic medicine. But many thanks for all the contributions, and we'll hope to speak to you again soon. And if the panellists can remain on the call, please, just for a couple of minutes. But that's us finished the session. Many thanks.
Thank you very much, everyone.
Thank you.